wanted special thanks and appreciation for the support of this program from the Massachusetts Behavioral Health Helpline, from the Massachusetts Behavioral Health Partnership, and for the MassHealth Office of Behavioral Health. I would now like to introduce to you Janice Sullivan, who is the interim CEO of Aspire Health Alliance, and she's going to share a little information with you regarding Aspire.
Thank you, Maureen. I am actually here in the place of my colleague, Marian Gerard Spino, who you all may know and is actually a member of this organization. I'm here just to give you a little brief overview of Aspire because we're one of the CBHCs across the state that you're going to hear about from my colleagues. But just briefly, Aspire Health Alliance was formerly South Shore Mental Health. We were founded in 1926, so our centennial's coming up. We have programs across the age span, starting with our early intervention program with babies, all the way through seniors. We have outpatient clinics in Plymouth, Marshfield, Braintree, and our CBHC site in Quincy. I'll skip over the description of the CBHC because you're going to hear that. But we also work in the community, in schools, police departments. We provide crisis services in various locations. We have residences for adults with serious mental illness. We have a day treatment program, and we have a strong peer recovery program in partnership with South Shore Peer Recovery. As I said, we're one of the CBHCs that were selected across the state, and we're thrilled we have been. We serve the Metro Boston South region, which is 10 towns in the South Shore, roughly from Milton down to Scituate. This model has been absolutely transformational for Aspire, and I believe it will be for the state as it grows. It's been a journey that we've taken together with our partners at the Office of Behavioral Health and MassHealth and MBHP at the state. And it's really, in my experience, and I've been around a while, it's been one of the most collaborative and strong partnerships that I've ever had with governmental entities. We're learning together, we're adapting together, and I am really proud of where we are today. So I'm thrilled to introduce my colleagues who know much more about this and will tell you much more. You can shift. So Margaret Eichner, actually we know really well at Aspire because for a while she was our OBH partner, but she is a senior policy manager at MassHealth's OBH office, where she leads policy development for the continuum of behavioral healthcare services. She's part of the policy team and supported the development of the interagency roadmap for behavioral health reform, which you'll hear is really where the CBHC grew from, which aim to strengthen behavioral health access and integration in Massachusetts. Go ahead. After her, you're going to hear from Heather Towers, who, like me, is pinch hitting a little bit at the last moment, and we thank you very much, Heather. But she is here in place of Donna Freitz, who she works really closely with. Heather is the VP of Clinical Programs at MBHP and Carelon Behavioral Health. She's worked in the managed care arena for 18 years, 14 years with Carelon, which formerly was Beacon Health Options. She's led clinical teams in over 15 states, focusing on Medicaid and Medicare and commercial populations. Her clinical practice is in crisis work, both in Massachusetts with the ESP program, which you'll hear has evolved into our mobile crisis intervention teams, and in New York City on an inpatient unit. I can vouch for the fact that Heather is passionate about supporting individuals to get the care that they need, because we've been fortunate enough to work with her as we've embarked on this CBHC journey. And Becky, I don't know as well, but she is, Becky Manseau Barnett is the Community Relations Manager at the Massachusetts Behavioral Health Partnership and is leading the new behavioral health helpline, which you're going to hear a lot more about, and is something that we value because it's a way for clients to get to us when they're in trouble if they may not know about CBHCs. She's a teacher, communicator, and a pastor, and she served as a community leader and connector, helping people to lead healthy and whole lives. And I thank all three of you for sharing your wisdom and knowledge about CBHCs tonight.
Thank you so much, Janice, and grateful for the introduction there. Echoing what Janice said, we've so appreciated that throughout all of the work that we'll describe during this session, that we have such strong partners in our providers who really do the great work of carrying out the vision and problem solving with us along the way. So I am excited to share more with you all from the perspective of the origin story, just so to speak, of the roadmap from the state's perspective. And so coming from the Office of Behavioral Health, there's a suite of changes that have occurred since January 2023. So hoping to provide some background on our work together and answer any questions at the end. Could you advance to the next slide? So again, as I mentioned, intending to outline changes in the behavioral health outpatient as well as the crisis systems as a result of what Massachusetts has called the Behavioral Health Roadmap, and discuss potential patient transitions of care, system workflows, and how individuals in Massachusetts can access these services. And we can go ahead to the next slide. So just to give a little bit of, as I said, the origin story, many of you may be familiar with what is both a national and a state issue. Emergency department boarding has been a large and increasing concern within the behavioral health field, with folks waiting far too long in emergency departments for the next level of care and the appropriate level of care. So since 2019, MassHealth solicited input from across the state to identify the specific pain points within the behavioral health system of care. And nearly 700 individuals, families, and others helped to identify challenges and gaps in the system at listening sessions across Massachusetts. Some of the highlights of the feedback, which you can see on the screen as well, were that hospital emergency departments previously were the only universal and commonly known front door to behavioral health care. People struggled to find the right behavioral health treatment with the right provider, with the right insurance coverage for them, including providers with cultural and linguistic competency. Behavioral health services are siloed, and that's mental health from addiction and both of those from physical health. So you can advance to the next slide. So what I'm sharing here is a lot of the initiatives, but in fact, not all of the initiatives that we've undertook from the state perspective to try to address those gaps and challenges that we heard. And we definitely understand this is a long process to move the system to serve our patients best. But describing a little bit of what we've done since most of these policies went live in January 2023. So first, to address that concern on emergency departments being the main front door, we created more and better front doors. So both a statewide live phone, text, and chat line called the Behavioral Health Helpline, or BHHL, which you will hear much more about from Becky. And that's a trained clinical staff triage for callers' needs and connection to care and scheduling of appointments after that triage. Additionally, we stood up a physical front door. So the BHHL is the virtual front door. We also stood up the physical front door as an alternative to emergency department care. And those are our community behavioral health centers, or CBHCs, which provide access to in-person care for crisis, urgent, and ongoing needs. And we've also done a number of other initiatives that support the overall system to increase access and expand availability of appointments. And so that includes increasing behavioral health integration in primary care through our 1115 demonstration, and including behavioral health as part of our ACO, primary care capitations. Happy to answer more about that. And also expanding not just in our CBHCs, but in our community mental health centers, trying to expand access through a program that we've called Behavioral Health Urgent Care. So through all of these, the intention is to integrate mental health and SUD. For example, CBHCs have capacity to serve both SUD and mental health. We also have created a universal insurance blind crisis system. So anyone who needs an initial crisis evaluation through the CBHC is able to call the behavioral health helpline or call a CBHC and access that regardless of insurance. And we intend to require more coordination between levels of care, including between hospital emergency departments and community behavioral health centers, including requirements to coordinate warm handoffs for discharge. So with that, that's an overview. Happy to dig into all of that, but I'll just go through briefly a couple more slides before I hand it off to my colleagues, if you want to advance. So just a brief overview of the model of that physical front door that I talked about, the Community Behavioral Health Center. There's a couple core components of this that I think Heather will also dig into, so I will leave it to her to fill in the details I miss. But essentially, the concept is to provide urgent and crisis responsive capacity, as I said, integrated mental health and addiction treatment, as well as integrating care coordination and relationships with community providers. So there's three main components within, or services within the community behavioral health centers. And that's mobile crisis intervention, which provides triage, evaluation, assessment, intervention, and de-escalation for those in crisis. There's outpatient clinics, which provide core integrated mental health and addiction treatment, including same or next day treatment for urgent needs, group therapy, and peer supports integrated. And then there's also community crisis stabilization beds, which are an overnight bedded service providing diversionary care for individuals who do not require inpatient psychiatric care, but do need a higher level of care than in the community. And this is available to both youth and adults. So that's a brief overview. I'll move on to the next slide. And as I mentioned, so in addition to our CBHCs, which act as the front door for urgent and crisis needs, we at MassHealth very much recognize that there's many other providers who provide urgent access for their members. And to encourage that, we have, as I mentioned, set up a program for behavioral health urgent care centers, which provide rapid access to behavioral health outpatient treatment with integrated addiction care to MassHealth members. These centers provide same or next day diagnostic evaluation for new clients and urgent appointments for existing clients. And they also provide non-urgent treatment within 14 calendar days. Urgent treatments includes prescribing for mental health, as well as initiation to medication for addiction treatment. BHUCs, as we call them, also have extended hours of operation outside of normal business, and they provide weekend hours to increase accessibility for MassHealth members. And next slide, please. So just a couple updates. We've rolled all of this out in January 2023. Since then, we've been closely monitoring with our partners at MBHP and our partners and our providers, the effectiveness and the implementation of all of these big goals. And we understand it's a culture shift for the system to achieve the goals of the roadmap. So we understand there's definitely more work to do on throughput and patient experience, much more work to do on connecting emergency departments and CBHCs, as well as work to increase direct admission to inpatient psychiatry units from CBHC settings. We're also working on increasing the connectivity of CBHCs with first responders and as well as the helpline to enable police drop-off at CBHCs. And we're continuing the work with our state partners to assess the feasibility of ambulance drop-off at CBHCs as well. So those are a couple of our major goals. And I have one more slide and then I'll pass it on to Heather and I will take any brief questions before I end. Just want to share this, it's in the slides for you. We definitely recognize, like, if you're hearing any feedback on your experience with CBHCs, we, as we monitor and try to support the system in rolling all of this out, we'd love to hear specific examples that you would like to provide feedback on. And also happy to, chat more after this if you have any questions on the system as a whole. But this is a portal for you to submit issues and incidents related to any of the BH roadmap services. And with that, I will pause. I'm not sure if I see any questions here. There in the appendix, there is a list of the CBHCs. So you can look at that, Aspire being one of those CBHCs, one of the 26. And if no questions, I'll pass it over to Heather.
Good evening, everyone. I'm Heather Towers, and I'm our clinical leader at MBHP. I'm actually going to ask you to hold on just this cover slide for a moment to give a little information of who MBHP is, right? And kind of who we are in relation to the state and MassHealth. So we are lucky to be the vendor for the Commonwealth. And again, as Margaret and others have said, are able to work really closely with a number of different offices under EOHHS, in particular, the Office of Behavioral Health and the Department of Mental Health. And in those relationships, we have oversight of a large number of MassHealth Medicaid members under the MBHP contract. So we'll do case management, utilization management, number of other things under that core contract, as well as through the roadmap, we are the oversight vendor for the CBHCs, as well as work closely with the behavioral health urgent care centers, and through our contract with the Department of Mental Health, oversee the behavioral health helpline. So we are very closely connected with our partners at OBH and DMH and have oversight of a number of programs through our contract. So hopefully that helps give folks a little bit of context of who we are. If you want to advance to the next slide. So we are just about, well, I guess it is 2 weeks. We are 1 year old and 2 weeks. So we launched the Community Behavioral Health Centers on January 3rd, 2023. And they are one of the physical front doors and truly a key component of the BH roadmaps, what we just heard from Margaret on. As Margaret shared, there are 26 CBHCs that are located in communities across the state. And the CBHCs were truly designed as an enhancement to, not a replacement of, an enhancement to the existing community-based behavioral health services that we have in the Commonwealth. We are lucky that we have a number of fantastic services that were already in place. And this design, the roadmap, was truly put together with the CBHCs at the lead to really enhance the services we already have in order to ensure that individuals of the Commonwealth have access to the right care at the right time, in the right place, whether that's at a brick and mortar, at a park, or in their own home. So again, there are 26 of the CBHCs located statewide, and their goal is to really ensure that people can receive, seamless and consistent care with the connections to treatment that they need at one location. So folks will see a lot, you'll see it on the next slide. We like to refer to like the house, right? We want everything under that one house, under that one campus where someone can come in or someone can call and get all the services that they really need, whether they're in a crisis or they're looking for some more ongoing outpatient services or some case management support. The CBHCs all provide triage and assessment of mental health as well as substance use needs. We certainly know that you cannot separate that. And the services are really followed by an array of different types of needs. So whether it's urgent, routine, a more imminent and acute crisis, there truly is a treatment option for everyone's need. The CBHCs also will be able to refer out, whether they're referring out through other components of their agency outside of the CBHC, or maybe to other specialty services and needs that are through another provider. So the concept is to truly have access to services at the CBHC itself, and then also for that CBHC to have the expertise and knowledge of their community to know when other referrals are needed as well. So if you want to move over to the next slide, please. And that's where we start to see the house. So all under one roof, or one campus of each of the community behavioral health centers, there's several different components of services. So there are the adult and youth core services. So this is truly where you are going to see your more urgent or ongoing, individualized, community-based outpatient services. These services are open from 8 a.m. to 8 p.m. Monday through Friday, and 9 a.m. to 5 p.m. on the weekends. The adult, youth, and core services are based on insurance contracts. So they are covered by all MassHealth Medicaid plans. And there are also a number of different commercial payers that also have contracts with the CBHCs for core services. The core services are a component that is based on insurance. There are a number of CBHCs, I do have to say, that will do some pro bono type work or have a sliding scale, either if an insurance is not contracted or if someone is uninsured, and will help to support folks to require the proper insurance, or if they're underinsured. But the core service components are focused on payer contracts. Now that is different with the mobile crisis services. So each CBHC also has adult and youth mobile crisis intervention services. So some of you may have been familiar with, I know I used to work at one, the old emergency service program model. So again, we're not replacing, we're enhancing. So this is truly an enhancement of that model. The emergency service programs certainly were fantastic and proved their value, but we've seen that we needed additional. So the mobile crisis services for youth and adults are provided at all of the CBHC locations, and they are able to see folks both at their brick and mortar, out in the community. So again, that's if you call and it's appropriate for someone to come out to your home, or if you're at a park. So you can come and see folks out in the community, and they can also provide telehealth. This is something that's available to everyone, regardless of insurance, 24/7, 365. And again, the modality of how folks are seen is really based on an individual's voice and choice, as well as what is clinically appropriate for the situation. We certainly want to ensure safety for everyone, and there are a lot of situations where we have co-response models. So folks will be able to go out with police or other first responders. So we really are able to be flexible and to provide folks what they need when they're requesting it. The third key component of the CBHCs are the community crisis stabilization programs. So again, these are separated for adults and youth. This is a voluntary 24-hour level of care. Right now, we have 18 adult CCS programs and 3 youth CCS programs that are across the Commonwealth. The expectation is that each CBHC, if they do not have their own adult or youth CCS program, that based on kind of the regional model, each CBHC has relationships and referral pathways to the adult and youth CCS programs to ensure that if they're seeing someone at their CBHC, they have relationships with other CBHCs. So if they have someone appropriate to be admitted to that program, they can absolutely do that. So again, these are voluntary 24-hour levels of care. These levels of care can support individuals who, again, are having both mental health and substance use concerns. So they can certainly treat folks with dual needs. What they cannot do, so this is not a detox, right? Again, it can support folks with dual needs, but if someone is having an acute detox need, that would not be appropriate for this level of care. They can certainly support folks who are having acute needs related to suicidality, psychosis, though these would have to be individuals who are voluntary and agreeable to treatment. So not having acute concerns and an inability to keep themselves or someone else safe. There is family work that is done on these units. There is collaboration and coordination that happens with outpatient providers and other social determinant of health support programs and needs. So this is a diversionary level of care from an inpatient unit that is housed in the community, but it is a 24-hour level of care and service. If you want to go on to the next slide. Okay, so this is also one of the slides that Margaret had up. We actually have 2 slides in common to really emphasize the importance here. So CBHCs have urgent and crisis response options. So what this will include is same and next day triage, evaluation, treatment, and stabilization. So when someone outreaches to a CBHC, if that's telephonically or if someone walks in, there is a capability in that moment to do a triage to be able to make a determination of what this individual needs. So is it truly that this is an acute need and we need to bring the mobile crisis intervention team in or get the mobile crisis intervention team out? Is this more of an urgent need and we can set up an appointment either for that same day, or if a person walks in, they'll be seen that day, or if it's over the phone, we'll be set up for later that day or seen the next day. There are mental health and substance use treatment options, again, for same and next day. There are a plethora of different treatment modalities through the outpatient and urgent model. So there are groups, there are peers, there are capabilities for folks to do MAT inductions, psychopharm, care coordination. Again, I talked about that collaboration with other community providers, and that includes primary care docs, specialty docs, schools, state agencies, and again, as well as referrals and connections to outside services and providers if that's what's needed. CBHCs can provide an integration of individualized services. So they're doing coordination and referrals to ensure, again, that individuals are getting the right care, the right time, the right place. And they truly are tailoring plans for those that they are working with, depending on what that individual's needs are and what their preferences are. And I named a lot of different modalities and services. They can really be used in conjunction with each other in a variety of different ways. So someone could come in and be met with immediately with a peer, could be set up with later that evening for group counseling, and then might get with their outpatient therapist the following week. So it truly is services that are available. It's a little bit like an a la carte menu, and they can be picked based on what fits for that person at that time. So we're really putting that focus on the person-centered care in the community with a goal of avoiding a more acute crisis situation. So really looking to address what is going on in the moment for that individual. So we're ensuring that we're staving off any future acute needs. So anyone who calls, walks in, is dropped off by a family member, police to the CBHC will have a triage assessment done on their needs and then connection to whatever treatment is appropriate based off of that. It's really important for folks to know and for providers to know when they're working with individuals that you don't need to know what service you want when you walk into a CBHC. That's what they're there for. That's what the triage is there for. So they will help both individuals in need and other professionals that are working with them make that assessment and help make that determination together of what the proper next step is. So we want to move on to the next slide, please. So this goes through, again, just a little bit of an easier list of some of those services that I talked about. So there's the intake services, screening, triage. Again, it kind of ranges from urgent to less acute and more standard outpatient services. There are capabilities, again, within same or next day for different inductions of buprenorphine, other, MAT services. There's also a connection to psychopharm within 72 hours. So there's certainly a lot of services that are provided at the CBHCs. So the core services themselves, so this is the kind of outpatient side of the house. So the non-emergency, the non-MCI. So that includes your urgent individualized treatment options. So that's your same and next day therapy appointments, access to clinical and support groups. A key part of all of the work that's done at the CBHC is also in the milieu team that's being brought in. So I've talked about peers, I've talked about clinicians, I've talked about some docs. There's also a heavy emphasis on utilization of nursing, really ensuring that nurses are both a part of the core services, so those outpatient services, as well as the mobile crisis intervention teams and the 24/7 CCS programs. So really ensuring that all components of the CBHC are including that milieu team and have access to the expertise of those individuals. There's peer and recovery support, prescribing capabilities like I talked about, and another key piece is medical screening, which happens both on the core services side as well as the MCI side. So this is done with RN staffing primarily, where if you come in to the mobile crisis, or if you're seen out in the community and there's a concern that there could be something medical going on, there are capabilities for the medical and nursing staff to be able to do a more basic triage screening. So almost think of it as like if you were going, when you walk into a physical health urgent care center and you kind of get that initial triage, right? They're going to do some general vitals, ask you some questions, now look at you and watch you, and be able to make a decision right then and there at the CBHC whether or not there's a need for more acute medical services and care. So this is one of the key components that was put in order to ensure that we were driving folks away from the hospitals and the emergency rooms, right? Really keeping that focused on acute medical needs, and that some of the more basic or common non-acute physical health needs can be managed at the CBHC by their nursing and medical staff. So that will occur both on the MCI side, so on the more acute side, as well as on the kind of outpatient core services side. So it's really one of the key pieces where the nurses can be used throughout that whole house of the CBHC to ensure that we're taking care of the whole person and not ignoring any physical health needs as well, or exacerbating any of those needs by having people waiting in an emergency room. If you want to move over to the next slide, please. Okay, so dives a little bit deeper into the mobile crisis interventions. So again, they're MCI for youth and adult. This is embedded within the CBHC, and as I shared, is available to everyone. So the MCI component is completely payer blind. So anyone in need of crisis services can utilize the MCI services. Again, they can be seen on site, they can go out mobile in the community, or also can see people via telehealth if that's what's appropriate. Goal here is that we're minimizing the use of the EDs. It's a bit of a theme, and really keeping people within their communities the best we can. Mobile crisis programs are a service, as I shared, you could have, I'm sure we all remember the ESPs. So they've been around for years, but truly now we're really enhancing this through the CBHC. And this is truly now, and again, a little different than how the ESP was. This is more than just an evaluation or a risk assessment, right? This isn't with the intent of, okay, we're evaluating someone, where do they go next? So we're really looking at this as an intervention. So we're providing the evaluation, the assessment, we're de-escalating, we're stabilizing, we're supporting, we're connecting, and at times we're being some of that ongoing or treatment and support in the community. That's because the MCI team not only operates 24/7, 365 for the initial eval, but they also will do a 3-day follow-up, an up to 3-day follow-up for adults, and up to 7-day follow-up for youth. So that's also included in the component of the services with the initial MCI eval. So that's different than where we were in our ESP days. Another difference is that the MCI model is most frequently delivered as a team, right? So again, I keep talking about that milieu. The MCI teams are really collaborating closely with their peers and family partners, utilizing those roles to truly help them engage folks. There are times when it might be a family member that's calling for someone and they haven't quite convinced their son or daughter that this is the right path for them to go for an evaluation. Our peers and family partners have been really supportive in getting that engagement from folks. And again, this talks a little bit more about the crisis stabilization units on here. I think I've actually talked through those, though I probably talked about them on the wrong slide. Sorry. One thing to add here that's been a really key component of the MCI program is the close collaboration that we've been having with community stakeholders. There's been a lot of work that has been done by all 26 CBHCs across the Commonwealth in the work that they're doing with their local law enforcement. So police can drop off to the CBHCs at any time of day, right? Again, 24/7, 365. And they can bring folks in for mobile crisis eval, or it may be that the police feel that someone needs an urgent appointment. Again, the key is that the police just can drop someone off. They don't need to know what they think the individual needs, but there's capability for the police to be dropping folks off at the CBHCs as well. And we've been seeing those numbers grow increasingly month over month with the number of drop-offs that have been happening. Culture change is hard, right? We know that historically at times it's been easier to drop off at the ED and kind of drop and kind of walk away. But the CBHCs have really been working closely with their police departments, as have our MBHP team, the Behavioral Health Helpline, OBH, really working hard to change this culture. And it's definitely been working. Actually, was meeting with one of the CBHCs just yesterday, and they were telling me that their police now chant CBHC instead of ED. So we're definitely making that culture change happen. If you want to move over to the next slide. So this just it shows you where all of the CBHCs are, so all 26 of them. Not sure if the slides are going to be given out, but the link itself will provide some general CBHC info, and then allows folks to put in some information and locate the nearest CBHC to them. So this is a resource to be able to click in, get some basic info, and then I think you put in your zip code and get the nearest CBHC to you. Next slide, please. So this is a little bit, I'm not going to read through any of these, but these are some of the success stories. And at this point, I feel like we could fill like 20 slides of success stories of what's been going on out there in the Commonwealth. What I want to highlight is that when you look at the success that the CBHCs have had, the key theme here is that we're truly avoiding folks going to the ED, avoiding having to have police responding and truly working with us, avoiding calls to 911, avoiding confusion for families, collaborating closely with schools. And again, really getting folks the right care that they need, the place that they need it, the time that they need it. So definitely encourage folks to read this and continue to look in here for other success stories, with the major themes are truly how we're redirecting folks to the right navigation of services versus going through some of the wrong doors that folks have in the past. You want to move over to the next slide, please? So the behavioral health urgent care centers. So this is another component of the roadmap. And it's similar to a component of the CBHC. So there are 26 CBHCs throughout the Commonwealth, and they all have a component of their programming of core services, where from 8 to 8, Monday through Friday, and 9 to 5 on the weekends, they have urgent access appointment availability. So same or next day. So the Commonwealth also has, I believe we are up to 53 behavioral health urgent care centers. These are also providers that offer timely access to treatment for individuals of the Commonwealth. So the same thing, they will be offering same or next day appointments. They do not have capacity for every weekend being open. Monday through Friday, they do all have extended evening hours to 8 a.m. And they have different hours of rotating their availability on the weekends. And they've really developed their hours based on how to best service their community that they're in. If you want to move to the next slide. Okay. So as I was saying, I think there's 56 of them at large. I believe there's like a little over 30 providers and a little over 50 separate sites that are throughout the Commonwealth. And it's a similar service that I described as the urgent access appointments for the CBHCs. So they're able to make appointments for diagnostic eval for new clients, again, same or next day. Same that they are able to do that for their existing clients as well. They also have psychopharm and MAT evaluation and induction processes and capabilities. That is within 72 hours. And then there's also the expectation that for any routine outpatient services or any follow-up needs, that they're able to schedule that within 14 calendar days. And again, this just has the link for additional information for the CBHCs as well as the behavioral health urgent care centers. For the behavioral health urgent care centers and the same and next day appointments, similar to that of the CBHCs, this is based on insurance status and what those contracts look like with providers. So as far as the CBHC and behavioral health urgent care models, it's the MCI, so the mobile crisis intervention component, that is payer agnostic, and the other services are based on insurance status and payer contracts. And I think if you go to the next slide, it's my last one. And it's another duplicate of Margaret's, but really here to emphasize, we want to hear your feedback. So please, this is a tool, again, as Margaret said, that anyone can support, anyone can put in information of, what's kind of going on there in your experience. We want the positive. We also want where our opportunities are of anything with the behavioral health helpline, the CBHCs, or the BH urgent care centers. I will tell you all that the second someone puts feedback in here, it comes directly to me in my email. And the team is incredibly responsive of getting back to folks within the same business day, or if it comes in on the weekend, the next business day. So please utilize this, share it with folks, because we certainly want to get feedback. I believe that was the last slide, but I do think I saw some questions come up in the chat.
There are a couple of them, Heather.
Okay. What commercial insurances contract with the CBHCs? So that is really, that's not something I know off the top of my head. I can share that there has been a lot of work done with each CBHC individually to work with the commercial providers. And it really is something that needs to be like looked at for each CBHC. And Janice, I may lean on you here. I'm not sure, or Margaret, I'm not sure if there's actually like one place that holds all of the information. I believe there's some information in MABA.
I think there's some in MABA and on the helpline too, right, Margaret?
I think the helpline has some information. I just want to clarify one thing, Heather, just to make sure folks are aware. So when we're talking about insurance contracting, depending on the CBHC, that is really for the core outpatient therapy services. Want to make sure that everyone knows that the mobile crisis services and the community crisis stabilization services that we described are available regardless of insurance. And so that's either the commercial insurance paying directly, a MassHealth member, or the state providing funding if the person doesn't have other insurance. So just want to make sure the crisis system is open to all comers. The outpatient ongoing therapy does depend on insurance.
Thank you, Margaret. I always leave out the CCS of that. I emphasize the MCI. So what I can share is, Janice, you're 100% right. The BHHL does have the information on which CBHCs are contracted with which payers. I was trying to think if there's a place, like a public place that has access for this, but the Behavioral Health Helpline definitely has this information. So when we have folks calling and outreaching to us, we're able to direct them based on their insurance. And then the other question are there similar services in neighboring states? Not to my knowledge of the way that we have developed the CBHCs. I think folks are probably familiar with the CCBHCs, so we have to get a little extra fancy and complicated always in Massachusetts, but there is the CCBHC, more federal model that does have a focus on outpatient and I believe crisis services, but not necessarily the full system of care, especially with the components of the 24/7 capabilities like we have in the Commonwealth. But I'm unfortunately not an expert on the CCBHC model or necessarily services in all of our contiguous states.
So I could add to that, and not much more than you can, Heather, but we started as a CCBHC, and that really helped us build the foundation. And Heather's exactly right. It does include that crisis component, the core services component, and the access to urgent care, and the integrated psychopharm services, the MOUD and SUD services. It's very, very similar, but not exactly as comprehensive as what Massachusetts is doing. And I do know we worked really closely with a partner in Rhode Island, in Newport, who is a CCBHC. And I do believe that they're in other New England states.
Unless there are any other questions that I missed, then I think we can move over to Becky, who I'm glad I'm not going after because she's such a fabulous presenter, and talk about the HHL.
Heather, there was one more under the Q&A box.
Oh, sorry. Let me see how to find.
Okay. That's okay. Sorry.
Just give me a moment to read it.
Okay.
Okay. So it says, if patients in crisis, who in the community is able to refer them to the CCS bed to avoid hospitalization? So there's a couple of questions in here, so I'll go through. So in order to be admitted into either the adult or youth CCS placement, there does need to be that crisis intervention. So if someone has an interest in that service, whether that's a family member, the individual themselves, a provider working with them, they would first need to be referred to the CBHC's mobile crisis intervention team, and that an intervention evaluation would be completed, and then a determination would be made from there for the placement. So that evaluation does need to occur through the CBHC. There certainly is education about the CCS that goes out to individuals right prior. That's a part of the mobile crisis intervention. There are actually a number of different tools that the CBHCs use to review what the CCS placement looks like. A number of the CBHCs, not all, actually have done really great videos that they can also share with folks. It's anxiety provoking, right? You're not going to be in your home. So there are some videos that they utilize to show individuals and their families, right? Especially if you have a child that is going to need placement, of what the program looks like, what the services offer. And then again, with that kind of intention and model of having everything in one house, folks can also see what the programs are looking like as well. And there was a comment on here of patients will first take themselves to the ED, thus bypassing the new system. So if an individual does go to the emergency department, the emergency departments, a small handful of them actually have subcontracts with the CBHCs. So it is the CBHC mobile crisis teams that are doing evaluations. But those hospital systems, which this is the vast majority, who are doing their own evaluations, they're all working collaboratively with the CBHCs. Again, culture change takes work and time. But there has been strong collaboration that's been happening where, again, the CBHCs have been marketing and educating the EDs on their services as well, and also sharing materials that they have and explaining what the CBHCs offer, what the CCS programs offer, and what they look like. Excuse me. So the true hope is that if someone does bypass and go to the ED, they will still have access to those same services, with the hope of learning in the future that if an event occurs, they can come to the CBHC directly and not have to go to the ED again.
I just wanted to add, Heather's exactly right that in order to access the CCS, the path is through the mobile crisis unit. With maybe one exception, if there are any people on the call who are working for inpatient psychiatric units, you can generally just call our CCS straight and we'll work with you to facilitate that referral.
Wonderful. Oh, yep. Okay, there we go. Hello, everybody. Again, I'm Becky Manseau Barnett, and I lead the community relations team for the Massachusetts Behavioral Health Helpline. I just want to take a second first to say, I just think it is really fabulous that all of you are here at 6 o'clock, probably after a long day. And I know it is because you care so much about the folks that you are serving every day. And you want to learn about these services as a way of increasing that care. So thank you for being here. It's really a gift to us to be able to share these services. So you have just heard about some of the new physical front doors for accessing behavioral health services in Massachusetts. both the community behavioral health centers and behavioral health urgent care. So now I'm going to talk about the new virtual front door. We hope a wide open front door for anybody and everybody to access mental health and substance use services in Massachusetts. So while we're right here on this slide, I just want to make sure and draw your attention to some of the most important information, and that is how folks can reach the line. 3 ways. Folks can call or text the number, which is 833-773-2445. Or you can head to the website, masshelpline.com, and utilize the chat feature, which is in the bottom right-hand corner of every page. You can call, text, or chat anytime, night or day. We can head on to the next slide. So the next question is, who can call the behavioral health helpline? Anybody and everybody in Massachusetts. It is a free service, so nobody is going to end up with a bill for calling the behavioral health helpline. And folks can call for themselves. They can call with somebody else or for somebody else. I'm going to say more about that in just a moment. We're working really hard to make sure that the behavioral health helpline isn't just available to anybody in the Commonwealth of Massachusetts, but that it's also truly accessible. So to this end, we have live interpretation in over 200 languages. We have resources for folks who are deaf and hard of hearing to access the line. And this is why you can access us one of 3 ways: call, text, or chat anytime, night or day, all year long. Now, what we do in essence is we provide warm handoffs to care. This could be for immediate crisis needs, for urgent or more routine needs. So I said just a second ago that folks can call for themselves. So let's say you have an individual you're working with, you encourage them to call the behavioral health helpline. They can call and they can right then and there be connected through this warm handoff to care. Let's say that somebody you're working with could use a little bit of extra support or encouragement to reach out to the behavioral health helpline. You could call with them and we can go ahead and provide that warm handoff to care. It could be that somebody is not in a place to call or to call with you, but you're curious about what resources might be available for this individual. So you could call. And in that instance, of course, we wouldn't be providing a warm handoff because the individual needing the services isn't a part of the conversation, but we can provide you with some ideas about what could be available for this person. So we are focused on providing connections to mental health and substance use services. We're a behavioral health helpline. However, we're fully aware, as you know, that when somebody calls us, there might be a mental health need, but typically there are a lot of things going on. So we might be listening to a caller and, yep, okay, we want to make this connection to a mental health provider, but we also figure out along the way, this person is hungry. We want to make a connection to a food pantry, or this person isn't going to mental health appointments because they don't have a way to get there. So in that instance, we're going to connect to resources for transportation to get the individual where they need to go to receive the care that they are in need of. We can go ahead to the next slide. So what does this look like and feel like when somebody calls into the behavioral health helpline? So let's take the example of Wasim. Wasim has been feeling anxious, increasingly agitated, and he gets to the point where he is going to reach out and ask for help. Magic moment, potent moment, when somebody gets to that place where they're willing to reach out and ask for help. We take that moment really seriously at the Behavioral Health Helpline. We want to steward it well. We want to receive Wasim with empathy and support, good old human kindness, to help him feel comfortable and at ease to share with us what's going on so that ultimately we can get him connected to the most appropriate type of care. So Wasim calls into the line and somebody from our knowledgeable clinical team will answer the phone. So we have licensed master's level clinicians who are supervising all of our calls. We have certified peer specialists who are part of the team, but then all of our call takers are trained and experienced in good old crisis skills, right? Crisis identification and action, de-escalation, stabilization. They're going to utilize these crisis skills to have a rapport building conversation with Wasim, and along the way to conduct a clinical assessment to determine Wasim's current level of risk. Every caller is internally assigned a risk rating, and that risk rating is going to determine what kind of connection to care we make. Risk rating could be emergent, meaning this is a crisis situation where we want to get Wasim connected to care very quickly in order to keep him or others safe. This could be an urgent situation where Wasim's okay for the moment, but we want to get him seen today or tomorrow at the latest in order to avoid getting to that crisis situation. The need could also be more routine in nature. Just want to say, there's a reason why Wasim's calling. So of course, regardless, we want to do everything that we can to get Wasim connected to care in a timely way. So the risk rating is going to determine the connection to care. We're going to go ahead and complete a warm handoff, which I'll say a little bit more about in just a second. But even that isn't the end of the engagement between Wasim and the Behavioral Health Helpline. We do offer a follow-up to every caller. The timing of that follow-up is going to depend upon the risk rating. So as you can imagine, for an emergent risk rating, we're going to be calling back pretty quickly within hours to make sure that Wasim's connection to care has been successful. For an urgent risk rating, we'll be calling back within 48 hours and at regular intervals thereafter until we are assured that Wasim is successfully connected to care. We'll ask to see if there's anything else that he needs, or maybe that connection didn't work for him and we want to try something else. For a routine risk rating, we're going to call back within 14 days and again at regular intervals thereafter until the individual is successfully connected to care. This follow-up has really proven invaluable. We know that there can be instances where a person might say, yes, I want help, let's set up the appointment, but then the day of the appointment comes and, oh, I feel a little nervous and I don't go. So we've had instances where that happens, and then we're able to catch the fact that the person did show up at their appointment when we follow up. And we can say, all right, no problem, let's try again. Let's make another connection. Let's get an appointment set up for you. And hey, next time, could we call you the morning of your appointment just to see how you're feeling about it and to provide any encouragement that would be helpful to you. We can head on to the next slide. So I said that the Behavioral Health Helpline is the new virtual front door for accessing behavioral health services in Massachusetts. Of course, it's not the only front door, and sometimes it's the sheer number of lines or services that can feel a little bit overwhelming for folks. So what we're working really hard to do at the Behavioral Health Helpline is to eliminate that hurdle, to take the burden of resource navigation off of the caller, and instead to do a lot of work behind the scenes, collaborating with existing statewide services to figure out, okay, when somebody calls us, where do they need to be? Do they need to be at the Behavioral Health Helpline? Should we provide some other connection for them? Our goal, let me say, really is to be a one-stop shop. We want to very minimally be kind of shuffling folks around. We recognize, again, that it was hard enough to make this one call, but this is also why we are participating in these collaborations, so we can minimize moving folks around, but doing so when that is actually the most effective and efficient option for the individual. So an example, the Behavioral Health Helpline might receive callers from 988 who say are in need of a more routine or urgent behavioral health need. 988 might send that individual over to us. Let's say the Behavioral Health Helpline is talking with an individual who really isn't interested in connection to treatment services. They just need somebody to talk to. And that's great. We're going to listen to that person. We're going to talk with them. And then as part of that conversation, we might educate them on what 988 offers, that, hey, 988 is amazing at this, providing supportive conversation, emotional support. So we want you to know about the service so that it's available to you, and we might even provide a warm connection to 988 where that makes sense. The point here is we're working behind the scenes with a lot of services in the state to take that burden of resource navigation off of the caller. We can head to the next slide. So where are we connecting folks for care? we get that question a lot, right? There are wait lists everywhere. Where are you sending folks? And sure, there are challenges. There are staffing shortages, but we're really excited about the extent to which we have been able to successfully connect folks to care in timely ways. Part of the reason for that are some of these new physical front doors in the state. We're certainly connecting folks to behavioral health centers. And as you already heard from Margaret and from Heather, we have mobile crisis intervention housed at all of our community behavioral health centers. So when we have a person with an emergent risk rating, very often we are connecting them to mobile crisis intervention. For urgent and routine needs, this is where insurance is going to come into play, as we've already heard a little bit about. Mobile crisis intervention, universally accessible regardless of insurance, available anytime, night or day, so we can go ahead and make that connection regardless. When the need is more urgent or routine as opposed to emergent crisis, this is where we'll talk with the person about what insurance they have, and we'll make a connection to a community behavioral health center, behavioral health urgent care, or to any number of local providers, supports, and services based upon availability of appointments, based upon insurance, and based upon particular needs. Let's say an individual needs a Portuguese-speaking provider. We're going to do our best to match accordingly. We can head on to the next slide. So this warm handoff, it's really a beautiful part of what happens at the Behavioral Health Helpline. It provides for a wonderful kind of human-to-human connection where people can feel held and heard and cared for. So we try and avoid, unless it's what a person asks for, to send callers away with a list of names and numbers that they need to call 10 more people in order to get their needs met. Instead, we're going to go ahead and connect a person to care right then and there. So let's take the example of Wasim. Let's say that we wanted to, it's an urgent risk rating, so we want to connect him to the local community behavioral health center for an urgent access appointment. With Wasim's permission, we're going to keep him on the phone and go ahead and initiate a no-hold conference call from the Behavioral Health Helpline with the Community Behavioral Health Center. So we get the Community Behavioral Health Center on the line. We're going to explain a bit about who they are and what they do. And then with Wasim's permission, we're going to go ahead and share a bit about why he's calling today so that he doesn't have to repeat it all over again. And then we're going to have a three-way collaborative conversation between the Behavioral Health Helpline, Wasim, and the referring provider, the service or provider that we're connecting him to. We're going to talk about some next steps, hopefully go ahead and get his appointment set up. Even that, again, is not the end of the engagement, because the Behavioral Health Helpline in this case will be calling back within 48 hours to make sure that Wasim had his appointment and to see if there's anything else that he needs. One little caveat to this warm handoff. We do offer it to every caller for an emergent risk rating. When we're connecting somebody to mobile crisis intervention, we can complete a warm handoff anytime, night or day, because mobile crisis intervention is open anytime, night or day. For routine and urgent needs, we still, when it's after hours, let's say Wasim called at midnight, we can still offer that warm handoff. It might just look like us saying, hey, Wasim, can we call you back tomorrow at 8 in the morning so we can get you set up with an appointment and do that warm handoff to care. We can head on to the next slide. So another way that we are trying to just make this process easier for the caller, to make it more accessible and comfortable to get connected to care, is that after we have made a warm transfer, a warm connection to care, so say in Wasim's case, and we get off the phone with him, with his permission, we're going to go ahead and securely share his relevant clinical information to the referring provider so that when Wasim shows up for his appointment, look at that, he doesn't have to answer all of the questions again because he is already in the system. We can head to the next slide. So I'm just going to walk you through sort of briefly a connection to care for each of the 3 risk ratings that I talked about. So when there's an emergent risk rating, I already indicated that one of the primary connection is to mobile crisis intervention. How that looks. So we're connecting somebody to mobile crisis intervention using our warm handoff protocol, that three-way collaborative conversation. The BHHL is staying with the caller. In that instance, we're going to have that conversation with mobile crisis about what kind of the best next steps are for the individual. Of course, listening to, say, Wasim, if we're tracking with Wasim here, to consider, is telehealth the right option, or does the caller have the capacity to get to mobile crisis intervention? Are they going to come to him? You already heard about this with Heather talking about what community behavioral health centers offer. But we're also going to have this conversation about what formal and informal supports Wasim has in place while he waits for connection to care. So we might, in talking with Wasim, realize, oh gosh, you have a roommate who is at home right now. Could we actually get that roommate to come in and join the call, see if they might be willing to just sit with you, hang out with you while you wait for mobile crisis intervention to arrive? Or you have a neighbor down the street that you feel comfortable with. Can we actually call them together right now and see if they would be willing to come and sit with you while you wait? Another option, we can offer scheduled phone calls from the BHHL with the individual while they wait for connection to care. The point is, this is a collaboration. We want to be supportive and help empower the individual to have what they need to stay safe while they wait for a connection to care. We can head to the next slide. So it's a very similar process for a connection to urgent care and a connection to routine care. It's just the timeline is a little bit different, right? So just to reiterate again, because this is important and I think helpful for folks to have clear, when we get to an urgent need and also a routine need, this is where insurance is going to come into play. Mobile crisis intervention, we're not worried about it. Anybody can access that regardless of insurance. So for an urgent need, we're working with the person to determine, all right, what's the best connection based upon availability of appointments, insurance, unique needs. We're going to go ahead and engage that warm handoff protocol to begin the collaborative three-way conversation. We're going to have that conversation about supports that an individual has in place. And what I want to say here about an urgent need is, let's say that an individual really doesn't have adequate supports while they wait for their appointment, and the BHHL is checking in with the individual and mutually agreeing, you know what, okay, we're going to escalate this. This is more of an emergent situation now. And at that point, we could certainly initiate a mobile crisis intervention referral. And as always, we're following up with the caller, no matter what, in this case, within 48 hours for the urgent need. We can head to the next slide. So for connection to routine care, very, very similar. Again, just the timeline is a little bit different. We're connecting based upon availability of appointments, insurance, and unique needs. The supports conversation. Let's say that an individual has to wait longer than we would like for, say, a connection to one-to-one therapy. It was deemed that's what the individual wanted, seemed like that would be the right treatment option for them. So we're connecting them to receive one-to-one therapy, but the appointment is further out than feels good. So we might have the conversation with the person about other kinds of services that we might connect them to while they wait for the one-to-one therapy appointment, be it a connection to a peer, or connection to a community-based support group, or connection to group therapy. And as many of the community behavioral health centers have found, because they offer all of these services and they're available elsewhere in the community as well, is that sometimes we'll connect somebody to, say, a community-based support group while they wait for their one-to-one therapy appointment. And it turns out, you know what, that community-based support group was it for that person. Maybe it was even more effective for them than one-to-one therapy would be. So a wonderful finding, which began as a bridge support while the person was waiting to be connected to another kind of care. Either way, this individual for routine need will get follow-up within a couple of weeks to make sure that the connection was successful, or to check in with the individual while they're waiting for connection to care, and to see if there's anything else we can do for them at this time. So we can head to the next slide. Those are kind of the nuts and bolts of the behavioral health helpline itself. Just want to make sure everybody heard me. It's free. It's free. It's free. Anybody can call. Nobody's going to get a bill. And it's a clinical resource. This is pretty cool. Folks can call and right then and there get a quick clinical triage and get this connection to a full range of care, whether it's crisis, urgent, or routine. So this opportunity for an individual to get the care they need when and where they need it, which is the goal of the roadmap as a whole. Now on the next slide, we can head there. You'll see again this roadmap feedback portal. You've seen it twice, but you're seeing it a third time because we mean this. We really want to hear from you when things are going well with the services, whether it be community behavioral health centers, behavioral health urgent care, or behavioral health helpline. We also want to hear when things don't go the way you expect. Let's say you or somebody you're working with utilizes one of these services and it doesn't pan out the way that we said here tonight it's supposed to pan out. We want to hear about that simply so that we can figure out what went awry and so that we can fix it for next time. So please do reach out to us. Heather can't wait to get your email. You can do that by going to the link provided here or go ahead and scan the QR code and you can check that out. We can head to the next slide. We are well aware that it's one thing to have these wonderful services available to us in Massachusetts, but if nobody knows about them, it won't do a whole lot of good. So we would love your help in spreading the word. Number of ways that you can do that. If you head to mass.gov and go to the BH Toolkit, you're going to find all kinds of resources available there. There's social media content, newsletter content, graphics that you can share, fact sheets. We also have available some behavioral health helpline print promotional materials that you can download or you can order for free to be shipped directly to you. These are available in 13 languages and we have wallet cards, posters and brochures. Our posters are available with a reflection of different demographics. You know, one has a younger person, an older person, so you can order the versions that are would connect resonate most for the individuals who might be passing through your office spaces. And again, you get a QR code there, but these links will be shared with you as well. You can head to the next slide. You can order those materials yourself, but if you like, even better, I am part of a larger behavioral health helpline community relations team. We do have 2 representatives in each region, and our team would love nothing more than to hear from you, to provide follow-up presentations, whether virtually or in person, to bring promotional materials to your office, to just simply sit down and have a conversation about the behavioral health helpline. And our team can also provide connections to your local community behavioral health center to really encourage that direct relationship. So we can head to the next slide. And I am happy to take questions. You see the number and the website there again, which is great.
I don't see any questions in the chat or in the Q&A. I'll just give a minute or so to anyone who may want to be entering something.
Sure, you know, and Maureen, while we give a minute for that, I know you all in planning for this had wondered how we handle it if a minor calls in. So maybe I could, I'm guessing others probably have that question, so I could speak to that as well. Anybody from Massachusetts of any age can call in. How we handle that when somebody is a minor. We've had instances of this. Let's say we have a youth who is, let me leave it general so that we can cover as much as possible in a short amount of time. If we have a minor calling in, we're going to see if we can, through the course of the conversation, you know, rapport building, see if we can get the child or youth to the point where they might be willing to bring a parent or caregiver into the conversation with us. If that isn't something we're able to do at that time, then we aren't able to provide a warm connection to care necessarily, but we certainly will send the young person away with some resources and maybe some encouragement about how they might talk to a parent or caregiver. Looks like we did get a question. How is this information available to the general public, social media, commercials, other? Yeah, great question. So a big part of what we've been doing over this past year is, of course, launching the behavioral health helpline itself and working hard to make sure that it's a really robust and helpful service for the people of Massachusetts. But getting the word out there about the service is key. So we have had a public marketing campaign that has had several phases since the spring. Hopefully you've seen the behavioral health helpline on billboards, digital ads, Facebook, Instagram. Coming up, I think it's going to be we're going to have ads on TikTok soon, radio spots. And there is going to be an emphasis in 2024 on making sure folks know about community behavioral health centers, in particular through the public marketing campaign. But then in addition, of course, I mentioned the Behavioral Health Helpline Community Relations team. They are available to come for presentations and meetings, but our team has also been just showing up anywhere and everywhere where people are, whether it be the Big E or an event on Cape Cod, everywhere across the state, showing up at community events with a particular focus on reaching historically unserved and underserved populations, to host behavioral health helpline resource tables, to get to know folks, to network, and to find new and increasing spaces where we can get the word out there. And the public marketing campaign has been in multiple languages, which has been important to us as well.